Hello and welcome to the Your Only Dog podcast. Today we are talking about IgG4-related disease, the great imitator that can look like cancer, infection, or several unrelated organ disorders. Picture a patient who develops painless swelling near the jaw and enlarged pancreas on imaging and tissue around the kidneys or aorta. Each finding may send the clinical team in a different direction, but sometimes they are parts of one immune-mediated condition. That condition is IgG4-related disease. Let us make this complicated diagnosis practical. Too busy? Here is your high-yield summary. IgG4-related disease is a systemic fibroinflammatory illness. It can produce swelling, masses, and progressive scarring in almost any organ. Common patterns involve the pancreas, bile ducts, salivary and tear glands, kidneys, lungs, lymph nodes, and the tissue behind the abdominal organs. The diagnosis is never made from the disease name or a blood result alone. Clinicians combine the organ pattern imaging laboratory information and, when appropriate, a carefully selected biopsy. The urgency depends on which organ is threatened and whether active inflammation is becoming permanent fibrosis. The term IgG4 can create a dangerous shortcut in clinical thinking. Some patients have an elevated serum IgG4 concentration, but an elevated result is not specific enough to prove the disease. Other inflammatory conditions, infections, and malignancies may also raise it. At the same time, a result that is not elevated does not automatically exclude the diagnosis. Tissue staining can show increased IgG4 positive plasma cells, but that finding also needs the right architecture and clinical setting. Think of IgG4 as one clue in a larger case, not as a standalone answer. Presentation depends on the organ involved. Autoimmune pancreatitis may cause pancreatic enlargement or obstructive jaundice. Salivary and tear gland disease may create persistent, often painless swelling. Kidney involvement can appear as tubulointerstitial disease or characteristic radiologic lesions. Retroperitoneal fibrosis may surround the ureters or major vessels and can quietly threaten kidney function. The lungs, lymph nodes, thyroid, meninges, and other sites may also be involved. Symptoms can be surprisingly mild compared with the appearance on imaging, which is one reason the disease may remain unrecognized until organ damage has progressed. A strong diagnostic approach begins by mapping every involved organ and asking whether the pattern fits one systemic process. Imaging helps define swelling, masses, duct changes, and fibrosis. Blood tests may support the suspicion and show organ dysfunction, but they do not replace pathology. When a safe and informative biopsy is possible, the site matters. Classic tissue features include a dense lymphoplasmacyte infiltrate, fibrosis arranged in a sturdiform pattern, and veins narrowed by inflammation called obliterative phlebitis. Not every organ displays every feature, so the pathologist and clinical team must interpret the specimen together. Before labeling a mass or swollen organ as IgG4-related disease, clinicians must actively consider alternatives. Pancreatic and biliary disease can resemble malignancy. Enlarged lymph nodes may raise concern for lymphoma or multicentric Castleman disease. Salivary gland involvement can overlap with Sjogren disease. Infection, granulomatous disease, and certain forms of vasculitis may enter the differential depending on the organ pattern. The ACR and EULAR criteria are useful for classification because they deliberately include exclusion steps, but classification criteria are not a replacement for bedside diagnosis. Starting immunosuppression before excluding a serious mimic can cause real harm. Treatment is guided by active inflammation symptoms and the danger of losing organ function. Glucocorticoids have traditionally been used to induce remission and often produce a rapid clinical response. But response to steroids does not confirm the diagnosis, and relapse during or after tapering is common enough to require a longer plan. Steroid toxicity also matters, especially in people with diabetes, osteoporosis, infection risk, or other chronic conditions. Maintenance treatment is individualized. The central goal is to control active disease before inflammation becomes irreversible. Fibrosis while using the least harmful strategy that can maintain remission. Now, let us go deeper. B cells and plasmablasts are important parts of the disease biology, which created a rationale for B cell depletion. Rituximab has been used as an off-label steroid-sparing treatment in selected patients with relapsing, refractory, or organ-threatening disease. More recently, the phase 3 Imitator trial studied inebilizumab, a therapy targeting CD19-positive B cells. It reduced disease flares and improved the chance of flare-free complete remission. Inebilizumab subsequently became an approved treatment for adults with IgG4-related disease in the United States. Treatment choice still requires specialist assessment, infection screening, vaccination planning, and individualized risk discussion. Follow-up should return to the organs that were active at baseline. Symptoms, examination, organ function tests, and imaging may all be needed. Serum IgG4 trends can help in some patients, but the value is an imperfect activity marker and should not be followed in isolation. A patient can have biochemical change without meaningful organ activity, or organ relapse without a dramatic laboratory signal. The other important distinction is inflammation versus established fibrosis. Active inflammation may respond well to treatment. Dense, long-standing scar tissue may not. That is why early recognition and organ-specific monitoring can change the long-term outcome. Number 1. Think of IgG4-related disease when several swollen, mass-like or fibrotic organ findings appear to belong to one systemic process. Number 2. Do not diagnose it from serum IgG4 or tissue staining alone. The organ pattern, imaging, pathology, and exclusion of malignancy, infection, and other mimics must agree. Number 3. Act according to organ risk. Control active inflammation before permanent fibrosis develops and choose glucocorticoids, steroid-sparing treatment, or targeted B-cell therapy through specialist-led individualized care. On the next episode, we will talk about how to measure blood pressure correctly at home. Follow the Your Only Doc podcast on YouTube and follow us on Instagram for clear evidence-based medical explanations. Tell us which medical topic you want explained next. Stay curious and stay safe. This episode is for education only and is not a personal diagnosis or a substitute for care from your own clinician.